West Nile fever is a zoonotic disease caused by the West Nile virus. The virus is an enveloped, positively stranded RNA virus from the genus Flavivirus. Other species from this genus include the yellow fever virus, dengue fever virus, and Zika virus. West Nile virus is considered an arbovirus, which is a group of viruses that are transmitted by arthropod vectors such as mosquitoes, flies, and mites. In the case of West Nile virus, the main vectors are mosquitoes from the genus Culex, particularly Culex pipiens, with birds acting as the reservoir for the virus. The virus is maintained in a cycle involving transmissions between birds and mosquitoes. Humans and horses are considered accidental and dead-end hosts. This means that humans and horses don't develop high enough levels of the virus in their bloodstream to pass the virus on to other biting mosquitoes. However, there have been a few cases of human-to-human transmissions through organ transplants, blood transfusions, and breast milk. In fact, there had been one reported case of a transplacental transmission of the West Nile fever. Introduced from the salivary gland or mosquitoes, the virus initially replicates in keratinocytes, neutrophils, and Langerhans cells in the skin. The infected Langerhans cells and neutrophil then migrate to regional lymph nodes to reach the bloodstream. Infections would then occur in tissues of organs such as the liver and the kidney. The infected neutrophils enable the virus to pass through the blood-brain barrier in a Trojan horse-like fashion. Upon recognition of the virus, production of pro-inflammatory cytokines increases the BBB permeability, which further facilitates the entry of the virus into the brain. Infected microglia and astrocytes in the brain releases more pro-inflammatory mediators, which results in an encephalitis and meningitis observed in severe infections. West Nile virus, first discovered in the West Nile region of Uganda in 1937, can now be found worldwide and is the most prevalent mosquito-borne virus in the US. In August 1999, the disease first appeared in New York City following an importation of infected birds, causing deaths in humans, horses, and birds, both in the wild and in captivity. The strain responsible for the initial North American outbreak was closely related to a strain isolated from a dead goose in Israel in 1998. In less than 10 years, it has spread across all of North America, including Mexico and Canada, and has just entered South America. During this time, the virus had already spread to the more southerly regions of Europe, Asia, and Australasia through infected migratory birds. The West Nile virus has a single serotype that exhibits considerable genetic variations. They have been classified into 8 lineages, but only lineages 1 and 2 contains the pathogenic strands for humans and horses. Lineage 1 consists strands from different geographic regions and is subdivided into 3 clades. Clade A contains strands from Europe, Africa, Middle East, and America. Clade B contains strands found in Australia, also known as the Kunjin virus. Clade C contains strands found in India. As for lineage 2, it is less pathogenic in humans than lineage 1, and it contains strands found exclusively in sub-Saharan Africa. However, lineage 2 strands have since been introduced into Europe, where the first lineage 2 human infection was reported in Russia in 2004. There are 3 categories of symptoms that have been reported in West Nile fever. 80% of patients do not develop any symptoms, while up to 20% of patients develop mild, non-specific symptoms such as fever, headaches, body aches, vomiting, and sometimes swollen lymph nodes or skin rashes on the chest, stomach, and back. However, 1 in 150 patients develop severe illnesses affecting the nervous system, such as disorientation, vision loss, paralysis, tremors, encephalitis, and meningitis. Encephalitis is the inflammation of the brain, while meningitis is the inflammation of the meningeal layer of the brain. Differences in virulence and neuroinvasiveness had been reported across different West Nile virus strands and lineages. While most strands from lineage 1 and 2 demonstrate high neuroinvasiveness, 2 isolates from lineage 1 and 3 strands from lineage 2 were found to be non-neuroinvasive. In addition, a strand KUN6453 in Australia causes lower morbidity and mortality compared to the NY99 strand from Clade A, isolated in North America. Despite the research, surveillance, and control measures, West Nile fever is now endemic in North America, with nearly 7 million cases estimated to have occurred since 1999, with outbreaks occurring every 8 to 10 years. In 2002, the disease exploded to most of the 48 states in the southern region, causing 4,156 diagnosed cases, of which 284 died. The highest reported cases, however, was in 2003, when 9,862 cases were reported. The estimated total number of cases were much higher because most cases are so mild that they go unnoticed and undiagnosed. Fortunately, this also means that the overall mortality rate for West Nile fever is much, much lower. And what about regions outside of the US? The largest outbreak of West Nile fever in Europe was recorded in 2018, where 12 countries, including Greece, Italy, and Spain, reported 1,548 locally acquired West Nile infections. This was attributed to favorable climatic conditions, namely an early spring and very high temperatures during the summer. Diagnosis of West Nile fever is confirmed by finding antibodies against the West Nile virus or the virus itself in the blood and the cerebrospinal fluid. There are no specific human antiviral treatments and vaccines available for the virus, but there are vaccines available for horses. Pain medications, intravenous fluids, and supportive treatments are used to reduce fever and relieve the symptoms in severe cases of the infection. Several human vaccine candidates remain in clinical stages of development. As of 2021, 9 clinical trials for human West Nile fever vaccine using 6 individual agents have been registered, but no human trial has progressed past phase 3. In fact, only 1 vaccine candidate ever made it to phase 3 clinical trials using live attenuated West Nile dengue chimeric virus. While the initial phase 1 and 2 testing for the safety of the vaccine can be performed using hundreds of participants, the vaccine efficacy must be demonstrated through phase 3 testing in populations affected by the virus. As West Nile fever outbreaks occur sporadically with varying affected regions, it is extremely difficult to evaluate the efficacy of the vaccine. Most control and prevention programs target the vector aspect of West Nile fever. The public is encouraged to avoid exposure to mosquitoes, especially at dawn and dusk, using insect screens and repellents, and to remove bodies of water from their household to limit the breeding site for mosquitoes. Since birds from the crow family are more susceptible to virus, finding dead crows can signal the presence of West Nile virus. Therefore, surveillance programs often encourage people to report dead crows for the testing of the virus. As global warming and the ever-increasing trafficking of animals facilitate the further spread of West Nile virus, scientists across the world are working towards a low-cost, high immunogenicity vaccine against the virus. In order to overcome the difficulties faced in the planning of efficacy trials, licensing procedures needs to be adapted and implemented for the health and safety of the population as a whole. Thank you.